Next speaker is one of the current giants in gynae-oncology. Professor Asima Mukhopadhyay is a gynae-oncologist as well as a clinician scientist working in both two continents, UK as well as in India. Amazing. She told me that she spent 6 months in UK and then another 6 months in India and doing huge amounts of surgery, research, clinical trials, organizational work in two continents. Really amazes me. She did her fellowship at Gateshead, one of the big centers in UK, and then subsequently during her PhD, she made an very important discovery that 50% of epithelial ovarian cancers are HRD deficient, and this has paved the way for the introduction of PARP inhibitor treatment in this group of patients. She then subsequently set up a large translational program of research in India that became the first research group in India to become a member of the prestigious GCIG, Gynae Cancer Intergroup, and created, therefore, a platform for patients in India to participate in clinical trials internationally. So she'll be the first and the best person to speak to us this morning on building sustainable cytoreductive surgical programs. Let's welcome Dr. Asima.
Yeah, how does it work? It's
Next
just that
and back.
next and back. So thank you very much, the organizers, for giving me this chance to come in over here. I realized Joe, who actually asked me to come over here, is flying to New York and shunted me to come here. But I'm very pleased because I've had some excellent lectures in the morning and my brain is really bursting. So as I go on to talk, I might just change a few slides on my speech, which will not match with what I've written over here, but I take on to my clues from my previous speakers. So as you have heard, that I have trained both in India and in the UK and in surgery and in science. And also I work 6 months here and 6 months there, but I do the same thing across both continents: cytoreductive surgery and research, DNA repair, which is homologous recombination and PARP inhibitors. And recently, my passion has been to work on health inequality. And I know we're talking about setting up a success, building sustainable cytoreductive surgery programs, but it is mostly in the low resource settings, although I have now also taken on doing this in a low resource area in the UK as well. And although I am involved in the discovery and development of the PARP inhibitors, it's nothing to do with this talk, but I'll show you during my talk how that experience in the lab has helped me to set up the cytoreductive surgery programs. So we're talking about ovarian cancer and cytoreductive surgery. That's the only thing I know, and it is important because it's severely underreported. It's going to be the next pandemic with the 47% increase in the next 20 years globally. It's the costliest cancer, women's cancer to treat. And if you see in India, the median age is 15 years younger than the Western counterpart. So we have a very large, younger population who are going to have this disease as a pandemic. It has changed significantly over the years. The survival when I started training used to be really not that good, but now patients can live more than 10 years. And I think there have been 3 major advances: understanding BRCA and BRCAness, chemotherapy, PARP inhibitors, and surgery. And improvement in all these 3 things have led to this improvement in survival. Now, when I started with my lab work, working on those first 2, I really thought that I don't need to train as a surgeon because they were doing wonderfully. But 10 years down the line, I come to the conclusion, and I'm going to modify my statement after this talk in the morning, but at least in my cancer, the good biology, or maybe I should say biologics, does not compensate for a poor quality surgery, at least for now. So 4 hours extra in theater, 4 days extra in HD or ITU does translate to 4 years of extra life. But things might change. That's a yo-yo game, but for the time being, it's that. So basically, we need to fix a goal point on defining a maximal effort. So either we can have a 5 p.m. finish. It's important because of several resource constraints. And then your residual disease will differ or vary. Or you can aim to remove all residual disease, and then the time will vary. So we have those two things to balance. And because we do not have access to the costly PARP inhibitors or other immunotherapy, and many, 70% of the disease is from low middle income countries. So in those situations, surgery is the most cost-effective cancer intervention for the disease. But then, of course, like transplant surgery, you need super centralization. But even in the poorest countries, you wouldn't do a cardiothoracic surgery in a primary center. You would centralize. And that's where we need to work on. And that's what I have been doing over the course of the last 10 years. Started in Tata Medical Center in Kolkata, which is a private organization. Patients are slightly well-to-do. Then I moved on to the most challenging experience, which is a government center where the monthly income of a patient family is less than $100. So you can imagine the type of patient population coming in to have a massive surgery like this. And then this is the recent the intervention which I've kind of embarked on. It's called ROC. It's an implementation research type of study developing as ovarian. And then in the UK, I'm working in northeast of England and in an area which has the poorest survival of ovarian cancer in the whole UK and in the whole Europe. But it is mainly due to the poor socioeconomic status in that area. And I've come to the conclusion, this is the first line of Anna Karenina, that all happy families are alike. If you go to a very high volume good center, you don't see. But then all unhappy family, or each unhappy family is unhappy in its own way. And I'm going to talk through a few of these unhappiness through my course of the talk. So basically, you're making a change, and as Michael Jackson said, when you're making these changes, you need to be the man in the mirror. So you need to change yourself first. Training. And then there is a balance needed for the pace you want to bring into the change. And that's what I have learned from my lab. It's good to be persevere and take your time, work through the failures. But then there are certain things, especially if you're working in low resource constraint settings, that you really need to do very fast, hit the rock. Otherwise, things don't move. So it's about understanding that balance and also the balance of the resilience and adaptation. Well, that is important. And there are several implementation research methodologies, which I didn't know before, but during the course I have learned. And it's very different to my lab work, but it's just been a fascinating experience to understand what is a normalization process theory, because that's what you're really working on, trying to make people realize things which hasn't happened before. And so basically, it's about identifying the barriers and challenges. And then I use a strategy called involve, a lot of people, and then you evolve. And this is the mnemonic that I have used for my implementation work. Is called EASE, which is like, it has to be, for anything to be successful, it needs to be ethical, easy, acceptable, affordable, sustainable, scalable, and effective. So let's just see how it worked. So basically, it's another thing, because I'm working simultaneously in both different settings and continents, so I have a consistency in approach. The protocols are, the core is same, but then I modify to make it population sensitive, specific, and systematic. And because you have to work with management all the time, you need to explain why you're doing this, why it is cost effective for that organization. The deliverables need to be, or the key performance indicators need to be really explainable and easily measurable. And I think training and education is an inbuilt program, as well as integration of research, and especially molecular research. Because I think maybe it is of most important when you are down to the poorest of resource settings that you identify the proper molecular select subgroup of patients where you're going to do a big surgery or targeted therapy. So that's why these key elements are important: patient selection, intraoperative conduct, quality indicators, and governance and risk management strategies, which again differ from center to center, but the principles are the same. So indications, I mean, we got guidelines. I'm not going to go into those. You just follow one of them. There have been a couple of debates whether complete or optimal debulking surgery, but in ovarian cancer, it's a maximal effort cytoreductive surgery. And this is where it becomes tricky, because when we train as general ONG, we are not trained to do all those upper abdominal stuff, and therefore maximal effort, it differs from different centers, different populations, different egos, if I may say, because everybody wants to think I'm doing a great job, but maybe in other eyes, it's not that great. And that's where you need to really come to the ground and accept the humility. And that's why all these determinants become important: surgeons, training, expertise, passion. You really need to have a stamina. It's a mind training, physical training. It's like you're doing a job like a fighter jet pilot. There has been a very big debate about whether to do neoadjuvant chemotherapy or primary surgery based on two big randomized controlled trials. But sadly, many people who were not trained or who wanted to finish their operation at 5 o'clock in the evening took that to their advantage, that neoadjuvant chemotherapy, shrink the disease, do a lesser surgery, is going to be beneficial. But over the years, we have learned that if you do it properly, then primary surgery is perhaps better. And that is why we got guidelines. So pretty much, if it's not infiltrating disease in the porta or disease in the route of mesentery, anything else, maybe you can operate in a primary surgery setting if the patient is fit. And it is really a bad news for us, because the chemotherapy maybe does not work that well in the type of disease. It's a cold tumor. It's an immunologically inert cold tumor, peritoneal spread. So maybe still we are stuck with doing these big surgeries. And even after NSCT, I mean, we need to look into the CT scan before the chemotherapy, not after the chemotherapy when we do the surgeries, because it shrinks, there's scars. And if you look into, I have grown these scars in the lab and they're still active. So it's about your identification of the scars. And now I look into the vascular patterns of those scars, and there's always this mosaic punctations, neovascularization. You think they're gone, but they're not. And if you don't take those out during surgery, which is incredibly more difficult, this is where you have the recurrences and the peritoneal recurrences after neoadjuvant chemo and surgery. So that's why, I'm not going to go through all these things. I mean, these are the determinants. Fitness assessments. Again, these patients have a lot of ascites and pleural fluid, and people think, oh, they're not fit. But take them out, give them a chance, they regain their fitness, and then you could do the surgery in most of the settings. So one thing I have learned through my life when working in India and in different settings, that we try to extrapolate the data which was developed in women 70 years old, 80 years old in many Western countries. And then I'm trying to put that data into my population. The median age of ovarian cancer in the poorest setting that I have operated, median age is 42 years. It's not 65. So they are actually fitter, they're nutritionally poor, they have survived TB, cholera, anything. So they're really intrinsically very strong, and they have that survival instinct. So try to put an operation data from somebody who was in the 80s to put into this population is wrong. And that's, I think, is important to get your own data to counsel your patients. And in our setting, again, looking into some trials, the primary surgery group do well. I'm not going to go through this. So these are the type of things. In India, I think if it's more than 70 years old, I don't like doing primary debulking surgeries because of a lot of reasons, but in UK we would still do. So, so there are certain things that you need to modify because of the other thing in India, at certain age of life, you tend to submit to God. So people don't want to become better. They think it's time to go. And if you got that mentality, it's useless doing a big surgery at that point of time because, they've just, the psychology is also, the health psychology and health literacy are very important factors in determining what you're going to do to your patients. So these are, again, standard steps I'm not going to go through. Very important to maintain a calm theater environment. And I always tell my fellows, halt, hungry, angry, lazy, and tired. Don't operate. Take a break, get somebody else to come in and do those operations. Because, if it's, because it's multi-organ resection, the chances of error is minimum. You stroke a pancreas while trying to do a splenectomy, it will insult you. So, you really need to be very, very, very perfectionist and meticulous in doing these operations to get a good outcome when you're doing so many procedures in a single day. And this is what I want Ajay to think about. You see, this is like power of observation. The same cells coming from the fallopian tube found the peritoneal fluid is circulating in your abdomen in your anti-clockwise fashion, hitting the cecum, then your hepatorenal pouch, and then the liver, the diaphragm, and then the foramen of Winslow, the hilum of the spleen. It never touches the outside of the spleen. We get less disease on the left diaphragm. And look, you've got the omentum with the fat cells looking like this. You've got the diaphragm with that sort of distribution of disease. Liver is not touched. And I wanted you to tell me why. I don't know the answer, but this is an observation I've met by, doing many, many surgeries. And that's why I start with making a small incision. I don't use a laparoscope because the unresectable things for me are for me to feel, which is infiltrative disease in the porta and root, which I can't do with laparoscope. So I make a very small hole, take a loop of bowel out, see it's free, feel the porta. If it's fine, good to go. Open the incision from Ziffy to the end. To the symphysis. And it's very important to have a systematic approach. I do, because there's a lot of VEGF, IL-6 inflammatory response, and there's a lot of fluid coming out as you do, and most of it's from the omentum. So I tend to take the omentum out first, and immediately you can see the patient is becoming hemodynamically more stable because the fluid production, it starts reducing. And then I do the upper abdomen because the one which bleeds is the pelvis. It's not the upper abdomen. So once you do the blood loss in the lower abdomen and you try to go to the upper abdomen, pressing the liver, trying to do those things and the patient doesn't like, and then you tend to leave very small disease behind, not resectable, but burn it out because the patient starts getting, so that's unstable. So that's why I do the upper abdomen first. Pelvis is always resectable. So that's the attitude, and it's normally for about every PCI3, it takes about an hour, so I can tell my anesthetist how long it's going to be. And this is an atlas. I tell my residents to take photographs of every PCI, every patient. And that's, maybe I'll put it into an AI algorithm one day, because this has taught me so much. You see that distribution of diaphragmatic disease is like a bit of a cauliflower thing, but I can tell you that's a good tumor. The one which is kind of really stuck like a plaque going inside, infiltrating, mesenchymal type of maybe extracellular matrix protein, that is a bad one. In my homologous recombination proficient and deficient tumors, the ones which have got BRCA, good biology, they have got that fluffy type of tumors. The one which is the chemo-resistant type, the bad ones, homologous recombination proficient ones, mainly have that infiltrating tumor distribution. And that's why, creating maybe these sort of pictures pre and post, you see lesser sac deposits in the groove of the ligamentum venosum. I mean, there are all these tricky organs which you really need to really explore very carefully in order to really give you a CC0. And this is a series we produced from both in India and UK. And you can see the areas in the lesser sac. I mean, people miss it. But if you start looking at it, and I use a laparoscope after the opening the abdomen to get a magnified vision inside the lesser sac. So you can see disease in all sort of these areas sitting. And it's important because optimal is less than 2.5 millimeter, or even less than a millimeter. And that's why you need to look into all this disease. And if you did a proper job, then I can show you just the bottom two, NGOCs in Gateshead in UK and TMC in Kolkata. But then at least the progression-free survival was not different between two continents, because if you did a good quality surgery, because the chemotherapy was similar. Overall survival in low middle income countries is never good, because we do not have access to trials and go into things again. So if you do a good surgery, you can get into up to the first progression-free survival, but overall survival becomes tricky afterwards. And again, as I say, pre and post imaging, systematic recording. Sometimes you need to have a look into the chest. But again, I have come to a conclusion that ovarian cancer spread is static. It's not a stasis. It's a disease of stasis. It's not about metastasis in that sense, as in the other organs. Now, just look into the pictures that this is an ESGO operating note of the sites which is involved with the tumors, and the procedures that you need to do to achieve a complete cytoreduction in ovarian cancer, is all sorts of areas. So in a center, if somebody is not doing these procedures enough, you've done 100 cases and you've not done a single cardiophrenic node or something, then maybe you're not looking into those areas. And then, of course, we use a standard database, which I haven't changed over the years in different settings. Post-operative management is one of the most complex post-operative courses, because not only the multi-organ resection, but of the massive SIRS response. And I'm going to show a couple of slides after that. So again, data collection. But this is very important, the cycle of an IL-6 VEGF-prone disease, to understand what happens in the post-op period. You've got a massive SIRS. Then you got CARS, which is an anti-inflammatory response, and this is where you have your immune suppression, and you have a massive incidence of maybe the pneumonias and the nosocomial things. Then it goes to MARS, and if you don't correct the MARS, then you go into chaos. And this, I believe, is largely driven by microbiome as well. So that makes it interesting in India, because in poor resource settings, we do a pre-operative stool surveillance culture, and 80 to 90% of our population, I don't know what we eat, but we have gram-negative organisms, or multi-drug resistant gram-negative organisms in our gut, even before we start the operating. So, I don't know, because of the gut handling or the LPS, immediately after the operation, there's this massive surge response. And, we looked into that. We looked into the antibiotic resistant pattern. And I mean, it's really very interesting, the amount of, I don't use antibiotics routinely in the UK, but when I come in India, I'm cognizant of this problem, and therefore, when we started using the UK protocol, it didn't work. We had to use the antibiotics that we needed to get rid of this problem. Otherwise, we wouldn't be having good post-operative outcomes. But if you can do that, we were the largest contributors in the multi-centric study. The quality of life is actually not that different, and it doesn't differ whether you do less procedures or more procedures, so you can do a lot of procedures to achieve cytoreduction. Last few slides, I'm just going to tell you about the model which I have achieved in every center that I have operated or set up a program. And this is a four-pronged technique. So you got research in the center, then you have cytoreductive program, that's on the top. You got a quality of life data collection, you got economic data collection, and then you got a project ovarian translational. So everything goes hand in hand in order to set up a program. So it's about setting an ethos or a psychology rather than just doing a surgery. And as you see, this is like a lot of barriers and solutions in each of these settings, each of these unhappy families. But this is the key, having a reflective practice, database, trials, things which we do normally in a high-resource setting, which doesn't even strike us. But then when you go to a center or a setting which doesn't have anything, then try to set up those itself is a big task. And that's why you need data, protocols, risk management, continuous medical education in a big team, sustainable collaborations. This is all, I mean, part and parcel. And this is just an example. When I started very much new in a center in Kolkata, this is what it used to be, 80% neoadjuvant chemotherapy because you can do operation in 2-3 hours. And then the recurrence between 6 months or within 6 months used to be 30 to 40%. When we changed the paradigm and I said to my managers that this is going to happen, you know, the red line is increasing surgical complexity, we're going to increase the morbidity, the black line, then we're going to learn how to manage the complications, so the complications will go down and your yellow line, which is your survival, or the gap between the yellow and black is going to increase. And I had to prove it. So every 6 months data, and then you can see initially you got complications, you got mortality, but then gradually it gets down. And what you find that when you reverse the scenario from 80% neoadjuvant chemotherapy to 80% primary surgery, then you actually see that your recurrence within 6 months is coming low and low, even lower in the primary surgery group. But now you are selecting the really bad guys to go into neoadjuvant chemotherapy. So still, you got a fair bit of recurrence in that group, but not in the majority of the population that we were going to see. And therefore, it's very important, again, to try to put everybody into some sort of clinical trial, surgical clinical trial, whether it's fluid or something. But it helps to improve the overall standard in your hospital. This is the second center which I was talking, and it's been the most incredible experience of my life because, as I say, it's a government center. The population is very poor. The doctors are very ill paid. So nobody wants to work in a government center. And you really get people who don't want to work or who don't want to excel come over there. And so in order to motivate the whole system, it is different. But then the young stars are your trump, right? Trump card. So you start with a fellowship. In my case, it was an International Gynae Cancer Fellowship. Started the program, get a young bunch of trainees to do all these things. They got excited. Straight away get into implement an ESGO audit standards, and then you start seeing things getting better. And even started a high-tech program. This is the first in a government institute in entire Eastern India, but I'm not doing it blindly. I'm doing it as something which I have learned with PARP inhibitors and with HRD, so a strategy using targeted high-tech and in a program. So it's like homologous recombination deficiency in the core, and then you have 50% homologous recombination deficient tumors which we are good with chemotherapy, and the 50% don't. So you're working to make the bad tumor group a good tumor group, the cold tumors into a hot tumor using heat. That's the cheapest. So, and that's, it's a PROHAT 4, hypothermia and HR. Then you got, there are a lot of things with, CSE, EMT, all these things happening side by side. But that's as a strategy to improve your outcome in the homologous recombination competent tumors, not the all of it. Because for the deficient, you've got PARP, you've got so many other things. I don't need HiPEC for those. So this is my original paper of developing the HRD and 50% competent and deficient. This is before TCGA, by the way. This is the first paper showing this 50% split. What is important that I looked later on, that the homologous recombination deficient, where the PARP works, where the platinum works, but you can even do a good surgery in those. It is the ones where the chemotherapy does not work, and even in the best hands in Gateshead, we got 62% optimal cytoreduction. That means the bad tumor does something bad to the periphery or the microenvironment, which even makes a surgeon's job difficult. So that led to us thinking that, what we should to do, and these are the bridge, this is Newcastle, this is Gateshead, and this is the Howrah Bridge on the River Ganges, but it's the same, it's a bridge between the science and the surgeons, and also to understand that the importance of microenvironment or the surgical microenvironment, deciding on what you should do and when you should do things. And that's what I said. We said the homologous recombination competent group might be the one where maybe the HiPEC will give you the maximal benefit. And this is the strategy that I have been trying to introduce in India and in UK as well, that HiPEC may be targeted in this subgroup due to compromise on the DDR. We have shown that it causes transcriptional downregulation of BRCA2, but also in the immunescape, with now data to show that the exhausted T cells become much better, functionally better after heat, and ECM modulation as well. Now, last maybe another 5 minutes if I've got. So this is like what happens in the lifetime of an ovarian cancer. So basically you do a good surgery, you may do some intraperitoneal therapy, then you do BRCA, then you HRD, then you give PARP inhibitors, then they recur, then something like that. In a high resource setting, it appears seamless because it's all funded. When you come to a low resource setting, there's a problem in each and everything on this. So therefore you need to be creative, you need to have an alternative, and that's why you see that it's really, you need to select patients, that you need biological subgroups, you need low-cost assays or diagnostic, rather than giving daily PARP inhibitors. We're now going into a study of giving intermittent PARP inhibitors. So, so basically, it's all about innovation. And this is what I had to give in my interview in UK. So this is my topic, achieving excellence in treatment of ovarian cancer in a health service with finite resource, which is NHS. So the first thing I said, excellence is always infinite and resource is always finite, right? So you really need to be creative in order to do that. And what I have learned from my experience of working in India, going back to UK now, that don't have much is not necessarily can't do much. So again, coming back to that, this is important. Involve so many people, so you need to give incentive, they need to be willing, leadership, people need to feel valued. The other people who are in your team, that, it's not you, but so many other people, encouragement, and then only it will evolve. So this is what, just 2 minutes more. So these are like each center. I've worked through the barriers which I faced. So for example, in a private institution, it's the cost of treatment, a lot of interpersonal factors when you are in a private institution with the surgeons. When it's a poor center, it's mainly education and training. In its UK, again, it's NHS theatre time and impact on the workload on allied facilities. My pathologists don't like when I give 31 specimens to them. So, there's a lot of things which you need to work with. But then there are a lot of facilitators. For me, the greatest facilitator was my director being a surgeon. in one of the cancer hospitals that I worked, because that was useful for me. And then the solutions that you create for each and individual setup. And it's just been a mind-blowing experience for me. And I've come to this conclusion, and it's not the strongest which survives, not the nor the most intelligent one, but it's the one which is most responsive to the change. And if you have some time, just read this book by Sir John Hunt on the ascent of Everest. There are a lot of things which, when you're climbing the mountain, that, to learn, they're translatable. But I think it's about, when you set up some things, you have to think about, right, okay, you're going to need the skills and the operations, and then each of them, there are technical and non-technical elements which you have to cope with. And in my experience, the greatest barrier is the practical, is getting the team and colleagues to sometimes stay back if they are not having the incentive or the education or the bug to be able to do that. So it's about health literacy and psychology. That is the greatest barrier in setting up big programs anywhere in the world. And this is the key performance indicator. Again, I'm going to put up in a paper next month. And this is my model of ease, looking into ethical, easy, acceptable, adaptable, affordable, sustainable, scalable, equip us, encourage early diagnosis. So how to implement and what the lessons learned I have, in working this model through in each and every center that I have worked. But as I say, it can be done even in the poorest and poorest of setups and in patient populations. Mentors help. Brendan Moran, he did give me his original MD thesis, which is the great green cover, which I have in my cupboard, to set up a high-break program. And they do help, actually, to have good mentors. I always tell my mentor, Bill, when I'm in trouble, Bill, speak to me. So then, I hear something which he has told 10 years ago, and it stays in your brain. And then it's useful to have great mentors. And so the next 2-3 minutes, this is a project which I'm embarking on in India now. It's called The Rock. It's a good name. But it is again based on the same thing. And most importantly, as I'm going to show you, it's using the benefits and the barriers which I have learned working both in private and in government models, and trying to put them together in a health implementation research framework. And there's so much research going on in health policy and health implementation, then that's useful. Again, you have to develop a workforce across, and that would be the dream, to work in many, many centers across the world through the IGCS program that we have, the International Gynae Cancer Network, so that the fellows from all around the world can come and train in a dedicated center, and they can feel that I don't need to go to US or UK, I can come to India in a center where to see people which resonate my population back home, and I can still do it. I think that's important for them to feel that it's not about only being in the biggest and the better places. I think this is the key message. Last line, that to make a practice which is based on evidence and not based on convenience. I think that is important. Sometimes we get sucked up into convenience dictating, and as I say, there's a lot of people, a lot of mentors and scientists, facilitators, management. It's really been a great journey for me so far, and thank you again for giving me this chance to speak. It's a very different talk. I usually talk about PARP inhibitors and science, but as I say, this is what I am learning. This is like another PhD I'm doing, perhaps, working out these models, but I just great to share my thoughts with you. Thank you.
Okay. Thank you very much, Dr. Asima, for a very inspiring talk with your surgical skills and your great vision for LMICs. Any questions for Dr. Asima? Yes, Glenn.
Asima, I've got a... Thanks, Dr. Asima. That is just breathtaking amount of work, and just had a real-world question for you. Okay, a lot of us, you know, I've had the honor of working a bit in South India and West Africa and things like that, and a lot of us do all this kind of research and a lot of funding and all this stuff and things, and then you give a talk like that that's a meaningful talk. My question to you is, in a real-world experience, when you're sitting there in front of a TMC patient who comes in, who can't afford anything, maybe might not understand anything, doesn't know what quality of life, length of life, and in your head, you've got mutational analysis and surgery and complications and in a real-world setting, as someone's probably the most experienced in the room in this, what's going through your head in terms of ethical tensions, and how are you resolving that with the patient?
So that's what maybe I could go back to one of the slides. So the first point in that ease model, I had put ethics, if you see that. So that is because I really didn't know when I stepped in India first that all that things I have learned, all the lab, all the PARP, everything that I have, now I've got a patient who really doesn't understand much. The common thing is that they think the doctor is a god and you do whatever you want. For me, patients sometimes, they're not empowered. They even, after I've done all the things, then they will say, okay, now please explain the same thing to my husband or to my family, because they're going to make the decision on their behalf. So I really struggled at the beginning, to kind of think, am I doing the right thing, taking out all the organs or, the complications and things and all. And that's what I realized, that, your precision has to be like a fighter jet pilot. There's no room for error here. And then, patient selection, again, I used to think, okay, it's not necessarily, if you've got a poor nutrition, poor albumin, I used to think that these are really bad prognostic factors. But as I say, the saving grace for me, in most of the patients, I call it a mother-in-law phenomenon. Maybe sound sexist, but when you are over 60, 65, 70 in India, the people don't bring people at that age, the women folk in that age, to hospitals for whatever reason. It's less. You get a concentration of young women coming to your hospital and with small kids. And for me, the only thing a mother of two asks you is, can you do something that I can make that little child go past the school? And so the perspective is changed, is different. And then, as I say, they have survived cholera, they have survived so many things in their life. I think, and I don't know what is it, that they have that immune, there's something, they cope with these things much better. They exercise, they work in the field, I don't know what it is exactly, but they seem to tolerate all these 8-9 hours whole surgery quite better. They're fit on the bed next day, they're breathing, they're doing things. I don't know, it's just a massive paradox. And again, as I say, I had bad outcomes when I didn't understand the microbiome, the LPS, the surge response, how to deal with it. But now, we don't think much. We got set protocol. I know it's going to have E. coli and Klebsiella, the moment I open, even if I don't do gut surgery. So we cover them with those. And I do see better complications in terms of lungs and stuff, and afterwards what it goes. So I have learned through my, experience.
Okay, thank you very much, Dr. Asima. Big hand for Dr. Asima again. Thank you.